Good morning, and welcome to today's Oncology Data Advisor interview. This morning, I have the pleasure of being joined by Dr. Komal Jhaveri, who is a breast medical oncologist at Memorial Sloan Kettering Cancer Center, and also the lead author of the EMBER-3 trial, which recently led to the FDA approval of Imlunestrant. And today, Dr. Jhaveri is here to share her insights on this approval. So thank you so much for coming on today. We're really excited to talk with you on the show.
Thank you so much for having me.
Absolutely. To start off, would you like to introduce yourself and share a little about what you do?
Absolutely. So I'm Komal Jhaveri. I'm a breast medical oncologist at Memorial Sloan Kettering Cancer Center. I have dual appointments actually within the breast medicine service and our early drug development service, where I also see phase 1 trial patients. And within the breast medicine service, I serve as the section head for our endocrine therapy research program, and I'm the clinical director for our early drug development service. So really involved with clinical trials, phase 1 to 3, and very excited about the EMBER-3 trial results, which led to the approval of the Imlunestrant drug for ER-positive breast cancer.
Absolutely. Looking forward to hearing about this approval.
Yeah.
So to start off, would you like to give us an overview of Imlunestrant and what this approval is for?
Yeah, absolutely. So imlunestrant is actually an oral SERD. And I think what we had recognized is while we have endocrine therapies and strategies that are very effective for ER-positive breast cancer, they have their own limitations, whether it's limited to toxicity, whether they are limitations related to the pharmacokinetic profile, or due to endocrine resistance mechanisms, especially when we're referring to ESR1 mutation as an important mechanism of resistance to endocrine therapy. Now, these mutations occur under the selective pressure of aromatase inhibitors in the metastatic setting and could be as high as 40 to 50% in the second or third line metastatic setting. So, really, we're talking about the largest subtype of breast cancer, which is ER positive breast cancer, and 40 to 50% of those ER positive breast cancers could develop an ESR1 mutation. And so, these oral SERDs, these novel endocrine agents beyond oral SERDs as well, are thought to be very attractive because they are well tolerated. They can overcome this endocrine resistance of ESR1 mutation. We had seen that preclinically, we had seen that in phase 1 trials, and now we have an approved drug, elacestrant, already in clinic. And now this is a second readout of a study, imlunestrant, in the EMBER-3 trial, which looked at monotherapy imlunestrant compared to physician choice endocrine therapy. And surely enough, we showed statistically significant outcomes in progression-free survival when we compared imlunestrant with physician choice endocrine therapy. I would also say that while we did not achieve statistical significance in the wild type tumors, this was majority of our patients that did not have a difference in superiority compared to physician choice. The hazard ratio there was 1, and the median PFSs were similar across. So it's not necessarily inferior to physician choice endocrine therapy in the wild type group. It's just that we were not able to show superiority in the wild type. And this is something that we've seen across this class of drugs, post CDK4/6 inhibitor, especially where the biology is a lot more heterogeneous, where we've only been able to show superiority statistically with monotherapy novel endocrine agent in ESR1 mutant tumors. That's where our approval is for elacestrant as well. And now we have that approval for imlunestrant in the EMBER-3 study as well.
That's wonderful. It's great to hear about these results in the trial and how exciting they are.
Yeah.
What is the impact of this approval on the treatment landscape for this population of patients with breast cancer?
So I think, we as a community have now appreciated more than one option for patients across multiple classes. For instance, we have 3 endocrine agents, meaning 3 aromatase inhibitors and tamoxifen as endocrine agents already that were available to us. We have 3 CDK4/6 inhibitors that we have in clinic, palbociclib, ribociclib, and abemaciclib. We have 2 TROP2 ADCs, sacituzumab govitecan, and datopotamab deruxtecan, already approved in HR-positive breast cancer, and maybe a third one that might potentially also get approved in the future. So we're used to having more than one option, and it's good to have that, given that while they are similar class of drugs, they still have some nuances in their toxicity profile. They still have some nuances that they bring on the table. And so for EMBER-3, we have that with imlunestrant, where elacestrant is already approved and available. Now we have imlunestrant available for the same patient population. There might be some nuances in the toxicity profile that one can look at. So we see a little bit nausea with elacestrant. Again, not high grade, very well tolerated drug. In clinic, some hypercholesterolemia that, the package insert does tell you to monitor. Imlunestrant, we don't have head-to-head trials comparing elacestrant and imlunestrant, but that has slightly more grade 1 diarrhea. We've seen that as single episodes with patients who had taken imlunestrant. But across the class, we're seeing very low discontinuation rates, which is nice to see. Also, we're seeing that when we ask patients about injection versus oral drugs, at least in the EMBER-3 trial, when we did that, more patients obviously reported injection site discomfort, redness, swelling, etc., with fulvestrant. So it does seem like, from a patient perspective as well, having an oral option is very, very attractive. Another unique aspect that I'll add for the EMBER-3 study is one of the cohorts that was added on early as a study amendment was to evaluate Imlunestrant plus abemaciclib. And the contingency there was that if you have any one of the endpoints for monotherapy comparisons positive, so if you have a PFS in all comers or PFS in ESR1 mutant tumors for the monotherapy statistically significant, then it would ungate the comparison for Imlunestrant abemaciclib versus Imlunestrant alone. And surely enough, with that strategy, when we had the statistically significant results, when we looked at this doublet versus single agent, we saw that the median progression-free survival was 9.1 months in the 65% of the patients who had already had a progression on a prior CDK4/6 inhibitor. So really, our patient population in clinic today who receive a lot of CDK4/6 inhibitors up front, 65% at least in the EMBER-3, when they got the doublet, despite prior CDK, had a 9.1-month median PFS, which is much higher than what we've seen with second-line strategies. So I'm really hoping that we have combination trials like this and combination data like this available to our patients in clinic so that we can further improve outcomes, even beyond the monotherapy drug options that we currently have available for ESR1 mutant tumors. Especially because these doublet data, it seems like, worked whether you had an ESR1 mutation or not. And that, I think, is very, very attractive because the monotherapy label is only for ESR1 mutant tumors. So really looking forward to seeing such data and hopefully in the future some approval around combination so we can further improve outcomes for our patients in clinic.
Absolutely. Going off what you mentioned about how the approvals for ESR1 mutations, how should oncologists in practice approach biomarker testing in light of this approval to identify patients who may benefit?
Fantastic question. I think, as a community, we have now appreciated that in the ER-positive setting, after progression on the first-line CDK4/6 inhibitor setting, predominantly our treatment selection is biomarker-based. So we have drugs that are targeting the PI3K, AKT, PTEN altered pathway in the second-line setting, such as capivasertib with fulvestrant and alpelisib with fulvestrant already available. More recently, we also have data from the INAVO120 regimen that led to the approval of another PI3K inhibitor, inavolisib, in combination with fulvestrant and palbociclib in the first-line metastatic setting. So I think we're appreciating more and more doing testing early on. So for PI3K mutations, we can do the testing from tissue or plasma because it's a truncal alteration. It's a clonal alteration that you can detect in the primary tissue and the metastatic tissue. And upon metastatic diagnosis, when we confirm the metastatic diagnosis, because we already have a biopsy sample, it's easier for us to think about, sending that tissue for NGS. But also, liquid biopsy is very, very attractive because the turnaround time for liquid biopsy is also very, very prompt, and you can get results up to 7 to 8 business days after sending the test result. So you can get a tumor profile of PI3K mutation, and you can also get a profile for ESR1 mutation, which is what we're discussing today. I think unlike PI3K mutation, ESR1 mutations are subclonal alterations that, as we said, are acquired under the selective pressure of therapy, and you can see the prevalence of 40 to 50% with cell-free DNA. So I think we can certainly send out a liquid biopsy sample, at least at the time of progression on first-line therapy, if not even sooner, but also a reminder that if we don't see it at that time, it's okay to retest it even after that second-line therapy in the third-line setting, because it's possible that depending on the tumor burden, if you had not detected that, you might be able to detect that even in the third-line setting. So I think we're becoming, as a community, more and more aware about testing and doing liquid biopsy, which is more convenient, which is faster, can be scheduled as a simple blood test that the patient can get, and the results can be available sooner as well, and can help us identify both ESR1 mutations and PIK3CA mutations, and therefore guide treatments based on that data.
Amazing. Really great insights to have. Awesome. So last question I have for you today, since we'll be posting this in October for Breast Cancer Awareness Month, do you have any messages you'd like to share with clinicians about the importance of continued research in this field, or what you're looking forward to seeing in the future, or any last insights about this approval?
I think, we certainly have embarked upon exciting times where, every few weeks we're hearing about a new drug approval or a new priority review or a new breakthrough designation, and certainly have made a lot of progress across subtypes of breast cancer. But I think there's still a lot more work to do. We still have a lot more to be able to offer our patients in clinic, whether it comes to early stage setting, whether it comes to metastatic setting. There's a whole lot more that we as a community need to do. And I think the Breast Cancer Awareness Month is just a reminder of how important it is for us as a community to come together to bring more awareness, to bring education, to bring, all this excitement and this hope to our patients, because there's certainly a lot more beyond the hope that we've been able to provide today. And so I think as this Breast Cancer Awareness Month is, encroaching upon us, I would just urge our community to just have this conversation with our patients, educate our nurses and our fellows who are frontline, discussants with our patients as well, to be able to make sure that they're doing their mammograms, that they are asking the right questions, they're being their own advocates, they're discussing clinical trials, they're discussing the new data that are coming out and new approvals that are happening to see how that would apply to them so that we can get closer to cure for breast cancer eventually.
Amazing. Perfect insight to wrap up on. So thank you so much, Dr. Jhaveri, for coming on today to tell us about this approval and all there is to look forward to in the future.
Absolutely. Thank you so much for having me.